Hello, and welcome to Dermatology Weekly, the official podcast of MDedge Dermatology, where we discuss issues that most affect the specialty. I'm MDedge editor Elizabeth Mishkati.
This week, I'm interviewing Dr. Murad Alam, Professor of Dermatology and Chief of Cutaneous and Aesthetic Surgery in the Department of Dermatology at Northwestern University. He'll be talking about some new recommendations about filler safety and a new patient safety database called CAPER, which was just launched by the American Society for Dermatologic Surgery Association for reporting adverse events associated with cutaneous procedures. Dr. Alam is past ASDS president and current chair of the ASDSA's Federal Affairs Work Group. He's also one of the authors of the paper, which provides evidence-based recommendations on preventing and treating adverse events related to injectable fillers. So thank you, Dr. Alam, for joining us. We can start with the paper, which was just published in the February issue of Dermatologic Surgery. And I was wondering if you can summarize the gist of the paper and highlight some of the important recommendations.
Sure, thank you for having me. So the paper is, if you look at it in isolation, a guideline for how to do filler injections and how to avoid problems. But I also want to place it in context. ASDS is perhaps the first society to ever develop guidelines on fillers. And this is the second iteration. The first iteration was about a decade ago. So I think it's really important to see this as an evolution. Now fillers are much more used than they were 10 years ago. And it's increasingly important for us to think about how do we do this overall extremely safe procedure even more safely. So I think that's where we're coming from in these guidelines. We thought a lot when we were developing filler guidelines, whether we should restrict ourselves to adverse events or talk about many other things. But it's important, we thought, to stay with adverse events for a couple of reasons. First of all, if you think about techniques of doing filler, where to inject, how to inject, exactly what it should look like, a lot of that is aesthetics, and there's a lot of variation in different individuals based on their age, their ethnicity, what they request, in terms of how that can be best optimized. So we didn't want to get into the weeds of telling individual patients or individual doctors what is appropriate for them, because that's very much a personal decision. However, it is important for whomever is doing fillers and whoever is receiving them to understand what the most important methods are to avoid problems, because those problems are similar regardless of what you're doing, and the strategies for avoiding them are equally similar in many of those instances. So some of the specific problems we were looking at is what happens when the filler goes to a place that you don't want it to go. So one of those problems, a simple problem, is a filler nodule. Instead of spreading out into the area you want it to go, it collects in one place like a little bit of a lump. So that's one problem we addressed. Another series of problems, or actually two problems, one slightly more minor and one much more concerning. What happens when your filler goes into a blood vessel? It can be a vein, it can be an artery, it can be a small vessel, a big vessel. That's a problem for a couple of reasons. One, the occlusion of the vessel, the blockage of the vessel, can cause damage to the overlying skin. And it can do so by stopping the blood supply to the skin and thereby causing some degree of necrosis, meaning skin death. And that's a problem, obviously, because that can be painful. It can look unsightly. People can get what's called reticulated erythema. They get this net-like red appearance that over time can become skin that is no longer fully functional and sloughs off. So that's something we want to avoid, because obviously this is a cosmetic procedure, and just as we don't want a lump, we also don't want an area where there's some skin loss. The other bad thing that can happen, rarely, exceedingly rarely, thankfully, with fillers that go into a blood vessel, is they can go into another blood vessel and another one and track down all the way to the central retinal artery. And when that happens, they go into the back of the eye, the retina, and they create emboli, which block off the blood supply to the retina. And that can cause visual loss. Thankfully, usually only in one eye, but sometimes even in both eyes, but almost always in one eye. Now, I can't emphasize to you enough how rare this is, Thankfully, never had this in my practice. I don't even know anyone who's had this in their practice. But as you can imagine, in doing a cosmetic procedure, you want to do everything in your power to avoid that type of bad outcome. So these were some of the issues we were addressing: how to deal with nodules, how to deal with intravascular injection, both to avoid skin necrosis or skin loss locally, and also to avoid visual problems. And there's some common features of how to deal with all of these methods and all of these problems. One is you have to really understand what instruments you're using, whether you're using a needle, which has a sharp edge, or you're using a cannula, which has a blunt tip and a little port to the side. You need to be delicate with how you're approaching the skin. You need to be careful how aggressive you are, how deep you are, how much back and forth you're doing, so that you minimize damage to the tissues as you're injecting. In addition to that, there's one other substance you probably want to keep around, which is hyaluronidase, which is a chemical that dissolves hyaluronic acid fillers. And most fillers injected in the US and worldwide these days are hyaluronic acid fillers. So if you get a lump, you could massage it. If not, you could inject some hyaluronidase to dissolve it. If you get an injection into a blood vessel, you can use hyaluronic acid to break up that occlusion so that the blood vessel opens up, there isn't skin damage, and the risk of visual impairment is reduced. So this is something that we really recommend everyone should have in their office at all times if they're doing fillers. I think that's one big take home. Another take home is there are times when a cannula might be better than a needle, because cannulas might at certain sites cause less trauma and thereby minimize the risks of some of these occlusive events. Finally, we also recommend, with regard to the visual issues, that dermatologists who are injecting consider entirely avoiding some areas if they're reluctant because of their higher risk. But even if they choose to inject those areas, they really should have an ophthalmologist colleague with whom they have a prior relationship and they know how that person likes to work and vice versa, so that if in the exceedingly rare instance there is a problem with vision, they can promptly refer a patient to that ophthalmologist, because really intervening in the first hour, even better yet in the first few minutes after this, dramatically increases the likelihood of resolving the problem.
And can you mention a little bit about the multidisciplinary task force that you had who worked on this? That included an ophthalmologist, correct? Or
Yes, as you know, there are now very clear rules. Many years ago, it was kind of ad hoc. Now there are clear rules on how to do clinical practice guidelines. And we very carefully followed those rules. So that also means that it can't just be you and a few of your best friends who come up with what you think is best. You have to have a representative group that includes people from multiple specialties, different kinds of experts, so that they can collectively look at the evidence. And the evidence is what you extract from the literature, the published literature, and put in evidence tables. So you get that evidence, and then we had, like you said, an otolaryngologist, an ophthalmologist, a number of dermatologists sifting through that evidence and trying to elicit the parts of it that were most useful to come up with our recommendations.
is there anything else about the paper that you would mention or highlight, or why you're doing it now, or is this the first such paper?
It's the second set of guidelines, like I said, that was about a decade ago, but I think it is timely. It's timely because in the last 5 or 6 years, there's been a lot of concern about some of these adverse events, notably the visual occlusive events. So I think it's important for an organization like ASDS, which represents the largest group of people probably who do this procedure in medicine on a routine basis, to come up with some recommendations. Now, there remain a lot of unanswered questions, but at least it's a starting point. It tells people what they can do. It helps allay some of their concerns. So I think it's timely in that regard. And I think ASDS is appropriate because many of these fillers, almost all the hyaluronic acid fillers, in fact, all the fillers in general, all the prepackaged injectable fillers were pioneered by dermatologists.
Dr. Alam, you were also involved in the development of the cutaneous procedures Adverse Events Reporting System, which is CAPER for short. And this is a collaboration between Northwestern's Department of Dermatology and the ASDSA. Can you tell us more about this?
Yes. What we wanted to do was to come up with a dermatologist-friendly system that would allow dermatologists and others to report problems they had while performing cosmetic procedures. Now, those problems could be the kind we've discussed, where there was a problem with the filler injection, it could be with a neurotoxin, it could be with a laser. We wanted there to be a friendly venue where you could report your concerns, what happened, and provide some information. And the purpose of this was to do a couple of things. First of all, if there's some new problems happening that everyone doesn't know about, this could be a way to get the word out to those people who haven't yet experienced it so they could take appropriate measures to avoid it. Beyond that, it's a way of the specialty, dermatology, dermatologic surgery, really taking the lead in ensuring patient safety. That's always been part of ASDS's mission. And rather than this data either not getting reported or getting reported to a lot of different people, so it's not all in one place, here we thought, here's a place where all of this data can come into one place. And so we also thought it'd be good because since it is in collaboration with ASDS, we thought it would reduce the anxiety that dermatologists and others often have about reporting something that wasn't that great to an authority that they're not really sure with what they're going to do with that information. So we were able to communicate that we will treat this with the utmost confidentiality. We're going to make sure that the information is kept safe and only used for appropriate uses.
The press release from the ASDSA also mentioned skin cancer related cosmetic or cutaneous procedures.
Yes.
Can you elaborate on that?
Yes. So, the reporting is really for any dermatologic procedure. It's not limited to cosmetics. We started talking about cosmetics with regard to the cosmetic guidelines, but this is really for any skin procedure that has an adverse event, especially an unexpected adverse event that isn't routinely expected after that procedure. So if it's a skin cancer that's being removed and being sewn back up and something funny happens, we'd like to hear about that. If it's an injectable filler or a laser, we'd like to hear about that. Any procedure that a dermatologist does, it could be a thread for thread lift procedure, it could be a liposuction procedure, it could be any procedure performed by a dermatologist. And we'd like to hear about it. Again, not in any punitive way, but really to enhance patient safety and to help maybe provide more information to others so that we can get ahead of a problem as it emerges.
And the reports are voluntary and de-identified according to the release?
They are indeed. We have a lot of mechanisms in place to make sure that this information goes absolutely nowhere. And even if ASDS were choosing to analyze that, there are a whole bunch of safeguards as to what analyses would be done, who would approve them, and so on and so forth. So yes, completely voluntary. We hope people will use it because we've tried to make the bar really low and make it easy to report. And hopefully we've tried to give people a lot of confidence that it's a safe place to report. So we're hoping that people will use it. Again, there's really no harm. Nothing bad's going to happen. There's a government system for doing this too. The FDA has an adverse reporting system, which is excellent. And we actually reached out to them and we said, can we use some of the questions that you use in your system in our system? And they were very, very nice and they were very agreeable and they allowed us to do that. So we're very supportive of FDA. We think they're outstanding. We just thought that having a system within ASDS is helpful because, again, it's more focused. It's about dermatology only. We believe that our members know us and trust us, so that's good. And we just feel that because it's voluntary, people might be more willing to report to our system than to the government, which I think often creates anxiety when people have to report to the government.
And is this for mild to any kind of adverse event, mild to moderate to severe?
It's pretty much for any kind of adverse event. And for those of us who've looked through the government reporting database, you can see de-identified reports there. And there's a variety and range of such reports. So I think what we're trying to do is we're trying to implement some quality control so we get a certain number of questions answered about every report that comes in. And some reports might be by chance alone. Like sometimes, you could have done A and B and C could have happened, and it could have been something totally unrelated, like the person got the flu at the same time, nothing to do with your procedure. So we don't want people to have to think too hard about, is this okay to report? If they have a gut feeling that they'd like to tell someone about this because maybe it's relevant, that's a good enough reason to report it. And then if that's the only report of that type we get, we're probably not going to do anything. But if we get 10, 20, 100 reports of something comparable, then that might be identifying a potential problem, which would then lead to, again, a very de-identified statement saying, we have heard that this could be happening, and you might want to consider X and Y.
That's interesting. So all the healthcare, is it just dermatologists, or can nurses submit reports, or
Any
even
healthcare,
consumers? Or
yeah, I think we've left it pretty open. We anticipate it's going to be mostly dermatologists because that's the group that's most closely allied to ASDS, but we don't want to be excessively restrictive.
And all they do is go to caper.net, then
Correct.
caper.net.
Yes, and there's information on how to report it there, as well as the actual reporting process is at that site. And if they have any questions, there's an info email address to which you can send your question and say, I'm thinking of reporting this, or this isn't working for me. So someone is there behind the screen to get back to you promptly and help you with that.
And anything else that I've missed on the caper system?
No, I don't think so. I think I really commend ASDS for doing this. I think very often we all, trust ourselves and our colleagues, and there's a feeling that we do everything very well. And I think that's true. I think dermatologic procedures, whether they're cancer or cosmetic, are exceedingly safe. And we have some of the very lowest adverse events rates, much less than 1% in almost all cases. So that's fantastic. But despite the fact we've done such a great job of making many procedures safer than they were before dermatologists got to them, I think there's always room for improvement. And I think what this does, it's us trying to stay ahead of the game and trying to be pioneers in further improving our safety and looking even more closely at what we're doing and having an early warning system. So I think this is, something that hopefully will bear fruit in the future and will allow us to remain the very safest specialists around.
So the FDA, none of the adverse event reporting systems maybe covered this exactly, so
Yes.
It doesn't really cover.
Well, it covers, and you can report anything that you could report to this caper, you could report to MAUD as well. And in fact, I think it's fine to report to both because we'll be able to avoid double counting because we'll know some details about the circumstances. The main purpose of this is really to encourage routine reporting. Because as you may know with the MAUD system, there are not that many reports in the MAUD system. There's a one of this and one of that, and that's not really enough to get a sense. So we want to make the bar really low. So let's say an average dermatologist sends 2 or 3, this would be, I think, an optimal case, slightly funny things that happen that year to caper every year. So we'd have thousands of reports. And a lot of those would be like, yes, well, that does happen a certain proportion of the time. And then some of those would be something new. So for the ones that happen routinely, maybe we could better understand those in the same way we understood some of the filler issues we discussed earlier. So that would be good. And for the ones that were completely new, then we'd learn about something completely new. So the goal is not to wait for the worst case of your life that ever happened and then report that, but to really use this as a teaching tool. So let's say if you have a colleague or a fellow and you say, well, that case last month, that was interesting. We didn't really expect that to happen. And that beyond that conversation will maybe be, should we just enter it into caper? Let's do that. So to have a low bar and to understand that none of this is getting back to anybody. So if you report 20 cases, we're not going to put up a sign saying, Dr. Jones reported 20 cases this year. Man, he must really be having a bad time there. Nothing like that is going anywhere. It's really just helping the specialty. It's just like helping to educate your colleague, which you might do informally. Here you're doing it, you're helping to educate the whole specialty.
That's interesting. That's exciting. I'm going to just say thank you, Dr. Alam, for joining us, and we look forward to interviewing you again in the future.
All of our podcasts are produced by Nick Andrews and MDedge editor Kathy Scarbeck. I'm MDedge editor Elizabeth Mishkati, and this is Dermatology Weekly.